Thank you very much, Professor Shen, and thank you very much, Dr. Müller, for your introductions. Let me open today's session, and it's going to be a long day, but also very exciting. You're going to have seen the program already. There's different subjects related to obesity, to diabetes, and to diabesity. Later we know what this term is about. And let me start off with the first session of the three by introducing you to Pascale Barberger-Gateau, who is head of the Nutrition and Epidemiology unit here at the Bordeaux University. Thank you so much for being here, and the first session is started now.
Thank you very much. It's my pleasure to open this first session. But first of all, I'd like to thank the Simsol as PhD students for organizing this international conference. The topic is very accurate, very relevant presently. I think there will be a lot of interesting presentations. I'd like to thank the speakers too for accepting their invitation. So now let's start first with setting the scene that will be presented by 4 PhD students. Agnieszka Kroll. Agnieszka Kroll is PhD student in biostatistics team. Her thesis is about the consideration of multiple events to analyze and predict the evolution of cancer, and her supervisor is Virginie Rondeau. Then we'll have Julie Gesson. She's PhD student in the HIV, cancer and global health and resource limited settings team of the INSERM unit U897. And her thesis is about malnutrition and HIV infection among children in West Africa. And she is supervised by Valériane Leroy, who is here. Yes. Then we'll have Kalina Rajo-Kalina, who is in my group in nutritional epidemiology. And her thesis is about determinants and prognostic value of advanced glycation and products at key ages. She is directed by Vincent Rigalo, who will come soon. He had to be at the hospital first, so he apologizes, but he will join soon. And last but not least, Louisa, PhD student in healthcare organization management team at the EHSP. Her thesis is about health technology assessment in Brazil. What are the lessons learned from other BRICS? BRICS is out. It's for Brazil, Russia, India, China, and South Africa states. That's it? Okay. A share model. And she is supervised by Martine Bélanger. So thank you very much. You have 20 minutes, but there will be no questions. So 5 minutes each. Okay.
So I would like also welcome you all from my part. And so we'll start with a quick introduction to the introduction. Because actually Judith has already speak about the doctoral network, so I will just briefly say that we are the part of this doctoral network, and thanks to that we have the opportunity to exchange with other doctoral students from public health. And this is the only doctoral network in France, and this experience will really is helping us for this exchange and to learn more and take more from our PhD experience. And in this aspect of the seminar, we are the representatives of 3 domains of this doctoral network from epidemiology, biostatistics, and health economy. I would like to tell first why we choose the subject of diabetes and obesity with current understanding and perspectives, because regarding our interdisciplinary aspect, we think that this major public health problem would be ideal to use our interdisciplinary approach in order to focus on this problem. With the worldwide tendencies of growing this problem in obesity and diabetes, and also the interconnections between these 2 pathologies, we think that this should be regarded in terms that most of these problems could be prevented. And using these interdisciplinary tools, we would like to focus today on finding some solutions. And also, this problem is a shared problem. So it is not, there are not specific populations that are affected affected by this problem, but it considers the developing countries and developed countries and young people and adults. Finally, I would like to say about this international aspect of the seminar, which came out during the preparation of the seminar, and we're really satisfied and proud that we could invite persons from Denmark, from Poland, and we will have also a researcher talking about Africa, and of course France. Here I would like to just focus on this Polish particularity, because the fact that we will have a presenter from Poland is not only that I'm Polish, but this is a particular case of how the historical and governmental changes affected the public health of this country, with of course increasing obesity in children and adults from the last 25 years after the political transfer, but also in some more historical aspects like Swedish disease, which affected the incidence of diabetes type 1, which will be taught in the session 1 in the Polish data.
So now, thank you. To continue this presentation, we will give you some key data and key information about obesity and diabetes. So first, about obesity. So the definition is abnormal or excessive fat accumulation that may impair health. So the body mass index is commonly used to define obesity in adults with this formula. And according to the WHO, the definition is BMI upper or equal to 25 defines overweight, whereas BMI above 30 defines obesity. But BMI should be considered as a growth guide because it's not really appropriate to define fat distribution and degree of fatness. So other skills like waist circumferences or measures of abdominal fat and so on could be better to qualify obesity and to predict chronic disease linked to obesity. So there are many causes of obesity. So it appears when there is a positive energy balance between caloric intake and energy expenditure. So it's because of an increase in intake of drinks and foods which are high in energy and with low energy value, with low nutritional value. And most of the time, these kind of foods are cheap and largely available. And also because of physical inactivity, which is increasing with urbanization and changing lifestyles, such as the nature of work, the mode of transportation, and so on. So obesity is a result of environmental and societal changes associated with development, but there is also other factors, as you can see in this figure, such as biological factors, which are involved in the emergence of obesity. So today there is a lack of supportive policies to prevent obesity, and it concerns many sectors, such as health, of course, but also urban planning, environment, food processing, distribution, marketing, and education. So most of these causes could be evitable with actions in these sectors. So we have to keep in mind that obesity is really a preventable disease. So obesity is currently viewed as a major contributor to the global burden of disease, and it's a major concern in our society, as we can see in the slides of threats. So it's linked to the crisis, social factors, the economics, production facts, and there is a lot of debate about how to deal with obesity now. So about the prevalence, so the prevalence has increased strongly in 30 years, as you can see in this figure. And for obesity specifically, the prevalence has nearly doubled since 1980. So more than 1.4 billion of adults are overweight worldwide, and 500 million are obese. Childhood obesity is also growing, so the prevalence of overweight and obesity have also doubled in 20 years in this population. And there are 170 million of children who are overweight or obese worldwide. And if we focus on the United States, a third of these children are overweight or obese. Even under 5 years of age, 42 million of children are overweight or obese. So it's worrying because among these children, half of them will remain underweight or obese in America. Moreover, among these 42 million children, 41 million live in developing countries. So it's shown quite well that obesity, the burden of obesity is a global burden. So now 65% of the world's population live in countries where overweight and obesity kills more people than underweight. So we have seen that obesity is highly prevalent, and the trend was to increase in most of the OECD countries. So in the last 30 years, as we have said before, the increase was global among all these developed countries. But there is also a major concern in developing countries, which could be explained also by the concept of nutrition transition. So a few words about that. The nutrition transition describes the evolution of dietary consumption and energy expenditures that are in relation with demographic and epidemiological transitions. So at the beginning, we had the era of hunter-gatherers, then there is an evolution to early agriculture, then industrialization with the reduction of famine, and the emergence of non-communicable disease and obesity-related disease. And the first step, the last step, is the behavior change, which is linked to the desire of people to have a healthier way of life and to prevent degenerative diseases. So for now, developing countries are facing the third and fourth patterns. They are not feeling the fifth pattern because in many of these countries, overweight and obesity are still viewed as a sign of well-being rather than a sign of health problem. So nutrition transition is a major driver of the increase of obesity in developing countries with rapid urbanization and physical inactivity, as we said before. So over the next 2 decades, it's expected a higher increase in the prevalence of overweight and obesity in low and middle-income countries. So in this context, we talk about double burden because within the same country or the same region, we have undernutrition as well as overnutrition problems in the population, and also we have infectious diseases such as malaria or HIV, which are still highly prevalent, but we have also non-communicable disease in large. So to finish, obesity have many health consequences, as cardiovascular diseases, diabetes, musculoskeletal disorders, or some cancers. So today we will focus on diabetes. So I can continue on this topic.
Thank you, Brigitte. So diabetes is a chronic disease which occurs when the pancreas does not produce enough insulin or when the body cannot effectively use this insulin. This leads to an increased concentration of glucose in the blood, or hypoglycemia. There are 2 main types of diabetes. In type 2 diabetes, the body is able to produce insulin, but the quantity is not sufficient, or the body is not able to respond to its effect for absorption of glucose, also known as insulin resistance. It is the most common type of diabetes. It represents 90% of the total cases, and it usually occurs in adults, but it is increasingly seen in children and adolescents. Almost half of the people with type 2 diabetes remain unaware of their illness for a long time because symptoms might take years to appear, and complication can be the first symptom. Type 1 diabetes is caused by autoimmune reaction, where the body's defense system attacks the cell producing insulin in the pancreas. This leads to incapacity of producing insulin. This type represents 10% of total cases of diabetes and usually occurs in children and adolescents. Type 2 diabetes is a multifactorial disease. Risk factors are well known. Many of these risk factors are modifiable to prevent the disease. and obesity are major modifiable risk factors, but they are also immediate, lack of physical activity or smoking, for example. Non-modifiable risk factors are, for example, age or ethnicity. Currently, the processes that initiate the autoimmune reaction in type 1 diabetes is not totally elucidated. Some environmental factors have been associated to the development of type 1 diabetes, such as viral infection or nutritional factors, while studies with dietary manipulation fail to give conclusive results. Diabetes is a serious global health problem. Today, 397 people live in diabetes, which is an alarming number, expected to rise to 592 million by 2035. Globally, it represents an increase of 50%. The highest prevalence is observed in Western Pacific, but the highest increase will be observed in Africa, where it can reach more than 85%. Despite the global impact of the epidemic, huge disparities in the world response can be observed. 80% of people with diabetes live in low and middle income countries, but only 20% of global health expenditure on the disease was made in those countries, which may explain the fact that 84% of people who are diagnosed live in low and middle income countries. In the African continent, where the increase is the most important, with the highest proportion of undiagnosed cases and a high rate of LVD due to diabetes, non-communicable disease, and are an additional burden with communicable disease. In low and middle income countries, the epidemic of diabetes implies important challenges such as early screening and the cost of care and treatments. Even though this country can overcome these challenges, an important aspect for the healthcare system will be the sustainability of the management and the investment, because diabetes causes long-term complications. Diabetes complications can affect different organs, the heart and blood vessel, eye or kidney and nerves. Poorly managed diabetes leads to serious and disabling complications. Although at the time of diagnosis, it's very common that at least one complication is already present. Now I'm going to let Lisa talk for the
conclusion and to basically introduce the term of diabesity. And just for your information, we displayed information here from the IDF, from the International Diabetes Foundation, which we would like to thank you as well. Outside we have placed a few catalogs, so it's really interesting to look at that. I think even here's a poster, so have a look at that. So so why do we talk today about diabesity? I mean, that's a term from the press that we just took over. Our seminar is not about diabesity itself, it treats obesity and diabetes, but we would like you to think about the links between both, and we'll have discussions together with you later on. So diabetes is occurring in the context of obesity, as we've seen beforehand, as it is the main modifiable risk factor of type 2 diabetes, and 90% of adults with type 2 diabetes are overweight or obese. So they're striking facts. And underlining also the relationship between both obesity and type 2 diabetes. You can see the risk, of course, the association between both. For obese people, a sevenfold higher risk, that's a sevenfold higher risk of diabetes, and for overweight people, this risk is of 3. So there are precise mechanisms linking these two conditions, but they remain unclear. And you can see that the fat distribution is an important determinant of the increased risk of diabetes, but there's still many open questions that we have no response for, that we can discuss together, of course, during this day. So our day will be organized in 3 sessions. First of all, we're going to talk about the problem here. What is the public health problem that we are encountering? looking at the social territorial disparities and associations of obesity, looking both at type 1 and type 2 diabetes. Session 2 will be about the risk factors and consequences for different age groups, where we look also at different, both at obesity, but mostly at diabetes here, starting with the role of the deficiency of vitamin D, diabetes in older adults, and also in the development context, as said previously. And thirdly, this is going to be an exciting session as well. It's going to be about the interdisciplinary approaches and perspectives, the core element of our seminar, which is an interdisciplinary seminar, where we're going to look at prevention as a topic and specialized obesity centers, for example, as well. And last but not least, at the interdisciplinary and European research collaboration efforts in the field of obesity. So you can see many different topics. So we also hope for your questions during that day. And I'd like to basically close and open up this introductory session by our student team by raising a few questions, and we'll definitely come back to all of these questions. So what can be done? What could be potential levers of action to the problems we just described? So could we change simply the diet of the affected, of the diseased people, of the whole population, or just of young people? Or should we only target those who have an unhealthy diet? What is an unhealthy diet, by the way? And, or should it only be of poor people because of social determinants? That are also an important factor. Should we change regulatory framework, or should we address here specifically cultural and dietary habits? Is that something we could do or should do? What about culinary know-how? Would we intervene there? Or what about the family uses, long-term history, family uses? Is there maybe a lever of action? What about the school? Prevention in the school place or at the workplace, the cafeteria, for example, where we eat on a daily basis. Maybe there has already been, action has already been taken and we don't know about it. So again, education is an important factor here, and the promotion, health promotion in general. We could also inform consumers better, you know, the whole information aspect, marketing. There's also a discussion about taxes, tax incentives for bad food, or penalizing food that is high in sugar, for example. There could be really, you can see here, just looking at these questions, there's so many things we can do, or at least that we could raise as a common discussion, providing this interdisciplinary approach, that we don't just remain in our own disciplines, but that we interact and create a common public health response. And that's where I would like to give back the floor to our chair of this first session, What is the Problem? Pascale and Barberger-Gateau, and our three presenters of this session, which Pascale and Barberger-Gateau will introduce to you. Thank you so much.
Thank you, Luisa. Thank you for all PhD students for, first of all, keeping your time perfectly. We started a bit late. And second, for raising these very important questions. And I'm not sure we'll be able to answer all these questions today, but it will certainly be the topic of the roundtable at the end of the day.